And this, along those same lines, is not the most common topic. This is an unusual injury, but it's worth knowing about. It's glenoid OCD. And here's a case. He's 22, he's a professional pitcher, he's got shoulder pain, but what's unique is he's got a mechanical symptom in his shoulder. He says, my shoulder catches. And sometimes we think about labral tears or instability as part of the catching. Here's another reason for it. You can see the red circles around the glenoid, and you see fluid going underneath what looks like either an enormous labrum or it's the cartilage. Osteochondritis dissecans is OCD, and it's much more common in other places in the body. Medial femoral condyle, number one, so in the knee. The capitellum, we see that in the young baseball players, sometimes in the talus and in the ankle. And since we know about elbow OCD, let's just concentrate on what it really is. It's a disease of bone. The bone gets weak, and the bone starts to lose its structural support, and then it can't support the cartilage, and then the cartilage, which is healthy, unsupported, starts to break down. Always happens with people who have repetitive activities and usually in high load, and the treatment's going to depend on the severity. Why does it happen? It's usually because the bone does not have good blood supply or it's compromised in some way, so it doesn't go through natural healing if it has some injury pattern. And often this is, for the elbow, it's the capitellum doesn't have great blood supply, and in the talus, medial femoral condyle, and in the setting of repetitive trauma. So therefore, big prevalence in our male throwers and also our female gymnasts for the capitellar OCD. Various stagings, there's numerous stagings for this. Some are very cumbersome. Easiest one, if it's non-displaced, usually not causing mechanical symptoms but pain, you can get away with non-operative treatment. Starts to cause mechanical symptoms, something is moving, there's either partial detachment or full detachment. When it's partially detached, usually you're going to wind up operating on them, and there's some controversy on what you're going to do. And we're talking about capitellum right now. We're going to get to the glenoid in a second. When it's fully displaced, you see the arrow, the piece is broken off, it's in the back of the elbow. Usually can't extend your elbow anymore. There's a loss of motion. That one, you take the loose piece out and you manage the defect. Well, let's get back to the glenoid. There's force on the shoulder, clearly, as Brandon told us about, and it's a complex movement. How big is the force? It's almost twice as big as it is on the capitellum. That's what happens in throwing. And of course, the motion is complicated. Scapular mechanics, throwing mechanics, there's variations amongst throwers. Certainly, these are going to contribute to some athletes having more force on their glenoid. So back to this patient, he's got this problem on MRI scan, and this is what it looks like at the time of surgery. I'm amazed this guy was throwing. Hey, take 2 weeks off and then get your rotator cuff strong and, do a bullpen. How's that going to work? Take the piece out, the date. I hate when the video puts the date on it because there's no hiding. This is 2013, so I'm using this PIC device. That's what we had at the time. And so we're going to try and create this big giant hole. We're going to create some healing. We can talk on the panel about novel ways to fill a hole now, but we're creating perforations in the bone to allow the marrow elements, so-called stem cells, to get inside the defect and cause healing. You can see the labrum to the left. The labrum is, if it's unstable, needs to be stabilized. On the picture that's moving, there is a suture there. We fix some of the labrum. Look, you get all of that beautiful marrow elements bleeding, and then we can get this potentially to heal. All right, let's have another case. This kid's a collegiate shortstop, so he's not a pitcher. He's got pain, and he says it doesn't mechanically hurt. I'm not getting stuck. And he fails and fails non-operative treatment, but he has pain when you load his shoulder posteriorly, just like we heard about in our physical exam. You push the head posteriorly, that's his pain. And here's his MRI scan. I cheated a little bit. When you have an MRI and you can look at it, you can contrast and you can change the windows, but it looks like there's a little cleft at the posterior labrum, right? Actually, the cartilage doesn't look that good either. I know some people are saying, I know what it is. I know how to game this presentation. There's an OCD of the glenoid coming. Yeah, there is. So we load him in the back. He's stable. He's not popping out. He's got a good exam under anesthesia. Here's his lesion. I actually was anticipating it, but didn't fully say it was going to be it. And anyway, we take the piece out. And there's a more recent case, so now we have cool devices. You can see him in the back. companies are out there. Drilling is different than microfracture now. This is a drill. Microfracture, you make cracks in the bone, and by definition, you're fracturing it. Sometimes you get a fracture response. We don't want fractured bone healing. We want holes in the bone. We accept a little bit of thermal, meaning it heats. Okay, rehab. Shoulder rehab, no matter how you cut it, it's a long time. This one's a long time too. No matter what you do in the shoulder, it's going to be a long rehab. The reports on this are very limited, so we can't go to the literature and say how great this is. We don't have HITS data on this. If you guys don't know what HITS data, we use this term a lot. HITS data is us looking at the MLB registry for the entire incidence or prevalence of the injuries, and we can learn about what their outcomes are. So we don't have MLB data on this right now. Okay, this is Mark. He's 21, he's a college outfielder. He's got the disease. Look at this MRI scan. Talked to him a lot about it. What's interesting is he's with his teammate. Same appointment. They're both in the same room. You know, when you go in the room and you see, if you have the same schedule I do, there's two people in the exam room that you're supposed to see, and then you got to figure out which one's Mark and which one's Anthony and who goes first and second, all that stuff. Mark went first. Anthony went second. He's a collegiate pitcher. I'm going to go back. Look, they're both 21. They got a similar MRI scan. I was getting lazy making these presentations. I thought I would just use Mark's MRI for this. This is actually Anthony's MRI. Put them both in. Mark and Anthony go to the same college. They're teammates. They are twins. So there's obviously a genetic feature of this problem. And in fact, for the kids, the gymnasts can get it in both their elbows. Throwers only get it in their throwing side. I have families where both the siblings, boys play baseball and the girls are gymnasts, and it runs in the whole family. Anyway, it's competitive forces. The bone is the disease. It doesn't support the cartilage. It's much more common in the elbow, but consider this as an issue in the shoulder. Arthroscopic treatment can be successful. I have one of those View Medi things if you want to see it on a little bit more of the details of the surgical technique. So simple little topic. Thank you. We're going to move on to the next.